intensive treatment versus the conventional treatment. And what it says, that if you treat the patient intensively to begin with, you get better benefit in terms of reduction of a cardiovascular event to the tune of 57%. So treating intensively and early, these are the type 1 diabetic patients who are managed on insulin therapy, aiming the goal of A1C of below 7%. So therefore, the aim is to get the A1C below 7 to get that benefit. Now the problem with the patient's management is the patient's compliance and taking the drug therapy regularly. This is the Kamlesh Khunti's study. He looked retrospectively to more than 80,000 patients from the United Kingdom. And what he saw, that patients taking one drug therapy, how long a clinician takes to intensify the patient, even in spite of the fact the patient is not controlled. If it's patient one drug therapy, the doctor takes at least about 2 years to intensify therapy. And the patient on 2 oral drugs, to intensify further, he takes at least 6 years. Till 6 years, the patient is off the control. And the patient with 3 drugs, he again takes 5 to 6 years to intensify. In other words, there is what is called as inertia in doctor's mind to initiate or intensify the treatment of diabetes. Now, what happens when you do that? Here is a patient whose A1C is below 7%, and here is a patient whose A1C remains above 7% because of lack of intensification of therapy in this group. And therefore, what happens is that at the end of 5.3 years, there is a significant increase of myocardial infarction by 67%, stroke by 51%, heart failure by 64%, and the composite cardiovascular endpoint by 62%. Means by not intensifying the treatment when it is necessary, you give this kind of a burden, which is called the glycemic burden, and this glycemic burden is a driver of all the complications that I mentioned so far. So this is what is called a bad glycemic legacy. In other words, you have been very, very lethargic into intensified treatment in these patients. And it's exactly what is shown earlier is emphasized here. When you give them 1 drug, 2 drugs, sequential addition of a drug therapy. In patients of diabetes, you can see here the A1C is as high as 9%, and you don't get the patient to target at all below 7%. He's always above 7%. And when you combine the drugs immediately, you can get to the target early. So the combination therapy improves the patient's compliance and therefore can control the diabetes effectively. So the ADA and ESD statement says that initial combination therapy brings about a greater reduction of A1C in the hemoglobin A1C when the metformin alone cannot do it, and a fixed dose formulation improves the patient's compliance and therefore the outcome is better. The ACE and ACE treatment guideline also says that the treatment of patients of a high A1C, more than 7.5%, should be initiated on a combination therapy, one option being metformin with DPP-4 inhibitor. That combination can be very good, and therefore this is complementary mechanism of action and again improves the patient's compliance. But the problem is the doctor's inertia, and this is the phenomenon is called as the failure of healthcare providers to initiate intensified therapy of diabetes in a timely manner. So most of the doctors do not believe in intensification of therapy. The patient continues to same drug as the patient remains asymptomatic. Patient is subjected to high glycemic burden, and therefore he has all those complications which I mentioned earlier. So the clinical inertia may be a number of reasons, and it because of the variation in the guidelines recommendation, lack of knowledge, cost of the newer therapies, and desire not to increase the pill burden to the patient. So there are patient factors and the treatment-related factors. The patient factor is the pill burden, and the multiple pills the patient doesn't want to take, and the cost of therapy is also increased, and the treatment-related factors are the clinical inertia on the part of a doctor, and doctor feels dropouts because of multiple pills. The patient may not come back to me, may not follow up with me because he says that I've given too many drugs to the patient. So the patient advantage of the early combination therapy is that early achievement of therapeutic dose, potential reduction in the risk and side effects if you combine drugs with lower doses, and the up-titration of single dose. If you keep on increasing the one tablet, the side effects of the particular drug going to be increased. Instead of that, you give subtherapeutic dose and give 2 drugs in combination. Maybe the patient will continue to take that because the side effect profile improves. The potential to delay disease progression, therefore, it's important that you intensify the treatment early and effectively. The individualization of the patient care approach is important because now we have a guidelines which are the individualization of treatment care. We all see the patient's key factors. If the patient is very old and he has got too many comorbid conditions, then he will not intensify treatment. If the patient is young and has enough productive life in future, so you would like to intensify, get the patient's goal of A1C below 6.5%. Consider specific factors which might impact therapy. For example, use the drug combinations which will treat the blood pressure also, treat his dyslipidemia, and treat his sugar. So buy one, get one free. So use the combination in such a way that the patient gets the benefit of not only controlling blood sugar, but also other comorbid conditions. Shared decision making. Discuss with the patient what you're trying to aim, what you're trying to achieve in your patient. Please discuss with the patient, and the patient should know. Patient and you should be on the same page. Patient is somewhere else, you are elsewhere. That kind of decision will not help the patient. Then management plan agreement, that you need to understand that the patient should agree to continue medications because diabetes is a lifelong disease. You can't stop it after 5 days, 5 years, 5 months. The patient has to continue, and therefore there's an ongoing monitoring is also important. The continual support both by the medical care and by the family members are also important, and that improves the patient outcome. The facts about metformin, we all know metformin is the first anti-diabetic agent to be used in every patient, and every algorithm, whether it's Indian or Chinese or US, FDA, or whatever it is, every guideline says metformin is the first drug. The problem with metformin, it has a half-life of just 5 hours. It is not metabolized, it is excreted as metformin in the urine. And clearance takes about 510, 1 plus 20 minutes. So that's about the clearance time of the metformin. It is absorbed by various transporters in the blood and is excreted unchained in the urine. Metformin is highly water soluble, therefore you need to drink large quantity of water. Now, challenges with what happens with immediate release metformin is that the absolute availability of 500 milligram dose is 50 to 60%, and it decreases as you increase the dose. If you give along with the food, it causes the problem in absorption. The absorption of metformin occurs in the duodenum, and metformin is highly water soluble, so water intake also results into rapid dissolution and sudden absorption of the medication. So therefore, extended release of formulation is preferred. Now, metformin immediate release, 90% of the drug comes in 30 minutes in blood, whereas 90% of the extended release comes over 10 hours. So therefore, you protract the action of metformin. The pharmacokinetic features of metformin extended release, the Tmax means maximum concentration is for 7 hours. Cmax concentration is 20% lower than immediate release because it is slowly absorbed, and the area under the curve is very important. What ultimately affects the therapy with metformin is the area under curve. These are all the nomenclatures used by the pharmacologist, and normally we are clinicians, we are not very familiar with this. But this is very simple to understand. If you take metformin immediate release, the GI upset result in the patient, say at the end of 3 or 6 months, and you see that as you continue with immediate release metformin, the side effect profile is very high, and these patients do not tolerate drug. If at all, the most important problem in metformin is the GI problems, and these GI problems are because in the duodenum, there are D2 receptors, and these receptors are stimulated by metformin, which induces nausea and vomiting. That's why many patients, when they take metformin, they tend to have these side effects. If we look at the absorption profile on the left hand, you see that the immediate release is immediately absorbed. If the drug immediately comes into circulation, the side effect profile is very heavy. If it is extended release, it slowly peaks up and stays for a long time. It's called sustained action, which is also called extended release form. And if you look at the dissolution on the right-hand side, you see the extended release dissolves very fast. Extended release dissolves very slow. The immediate release takes time. Immediate release immediately gets absorbed in the blood. So this is a special technology why do we need extended release formulation, which is called a technique called gastro-retentive drug delivery system. And it's a very important system because it is one which allows the drug to stay in the stomach for longer time. If the drug stays in the stomach longer time, it is slowly released in the duodenum, so the absorption becomes very slow. And therefore, there are various drugs which are used which have this kind of technology. For example, if you have ranitidine, metformin, amoxicillin for that matter, some of the examples where we use this technology where the drug stays in the stomach for longer time and that becomes a reservoir, and from that the drug is slowly released into circulation, and therefore the patient does not have any adverse effect of this thing. So there are a few types of gastro-retentive drug delivery system, and a DPP-4 metformin extended release is one of the combination that is available. So the advantage is it reduces drug frequency, it changes the PK/PD profile of a drug, and therefore there's an improved bioavailability of a drug, and used to sustain delivery drug for a long time, and it has got a big therapeutic window. The advantage of these extended release tablet is that the drug absorption is very slow, the side effects are less, and only 60 to 70% drug is absorbed. The remaining part of the drug is pushed into the intestine. On the intestine, they work on the microbiome and improves the quality of microbiome. And also by doing that, they stimulate the release of GLP. So therefore, the extended release might be costly, but a lot of benefits when you use in these patients. There are certain disadvantages in these patients that they call floating system. The patient has to have enough amount of fluid in the stomach, so they has to drink little large quantity of water. And patient takes a tablet, immediately sleeps. The contraction waves can sweep away the drug into duodenum. So therefore, you should advise the patient that don't take it just before going to bed. Take the tablet, wait for some time, half an hour to 1 hour, and then go back to bed, and do not immediately lie down. And therefore, this is a certain important instruction you have to give the patient when you use this kind of therapy. Now, there are two techniques in which you can extend the release of action of metformin. One is called Acuform tablet, and the other one is called dual matrix polymer hydrophilic system. Now, what actually this means is this particular drug is encoded in particular a double polymer, and this polymer is actually not soluble, and the fluid can go into it, and as the fluid walks into the capsule, a certain amount of drug is released by the capsule. Many times the patient comes and tells you, whatever drugs were given to me, next day I saw it in my feces. That means the drug is not working. Actually, this is not a drug, it's a ghost tablet. The content of the drug is already passed off. The polymer on top is not digested. That's the basic function. And it works as an osmotic pump. And as the fluid walks into it, little amount of drug is released from the other side. And therefore, these are two kinds of technology we have available for the use of metformin. And they have, in Acuform technology, it's a single layer polymer. And in dual, as you said, dual hydrophilic, it is a double layer. Types of polymers are only non-ionic. Here it's ionic and non-ionic are used. These are all the complicated words. Don't use it. But remember there are two kinds of technology. And sitagliptin with metformin extended release comes as the Acuform technology, which is available in the market. And saxagliptin metformin uses the dual hydrophilic technology for the purpose of combination therapy. So therefore, when you have this tablet, for example, this tablet the patient is swallowed, this tablet is in the stomach, and in the stomach it stays for a long time. It is there again, and she's still in the stomach for a long time, and it swells up. As the fluid walks into it, it swells up, and it swells up, it reaches the pylorus, cannot go beyond the pylorus, and therefore stays there for quite some time. And from that slowly, it's a floating tablet in the stomach, and eventually small quantity released from this particular tablet, which goes to duodenum, which is the site of absorption of the metformin. And here you have a double coating, which you see on top on the right-hand side, where the top coating is of saxagliptin, which is first absorbed, and then the water walks into the particular dual polymer, and the polymer swells up, and slowly the drug is released. So therefore, the advantage is that the side effects are less. The second advantage, I think is more important, is the renal benefit. We all worried about using metformin in patients with chronic kidney disease, especially the GFR around 45. This particular molecule can be used because it's only 60% of drug is there in the circulation and 40% of drug goes distally into colon, acts on the microbiome. So therefore it has renal safety, it has the safety in terms of the side effects, and at the same time the efficacy is quite good. So therefore the combination we have is linagliptin and sitagliptin and saxagliptin and vildagliptin. Along with that we have metformin. Extended immediate release is available with linagliptin with metformin. Sita-metformin immediate release is available. Saxagliptin immediate release is not available. It's only the extended release is available. It's a fixed dose combination and a single pill, and it is also has a CV safety and a CV neutral effect. Vildagliptin with metformin is immediate release. The extended release is not available. Only with sitagliptin is available, but there are two different tablets. Only in the Western countries they could get in one tablet. It's available as a fixed dose in one tablet. But in India, the two tablets are given separately. One tablet is sitagliptin, the other one is metformin extended release. Many times the patient keeps on taking only sitagliptin and then later on takes only metformin. So this becomes a problem. We need to educate the patient. Sometimes I tell the patient to get back the tablet, show it to me, and tell him exactly how to take this tablet. Otherwise, the patient lands up in trouble, takes only Sita or only metformin, and then takes only Sita later. So remember that instruction is important when you give that kind of combination. So here's a study which looked at the combination of saxagliptin with metformin and up-titrating metformin XR. Obviously, when the combination is given, it does definitely better and a better A1C control when you have a combination of metformin along with saxagliptin. And here the study, which is a phase 3 and phase 4 week study of a multi-central multinational study where you have a combination and the metformin in a single tablet. And you see the dark line which shows the combination therapy in 24 hours glucose profile based on the repeated blood sample examination on SMBG. And you see that the combination therapy definitely has the better effect. The A1C to begin with was 7 to 10% is reduced significantly when you use the combination of these patients. So therefore it's effective and useful. So to conclude what I said so far in the last 15 minutes, early and individualized treatment approach is recommended as per the most of the current guidelines for the diabetes management. Early and intensive control with a combination of anti-diabetic agents will have a better patient care and a patient control and a reduced progression of a disease. Metformin is the first anti-diabetic agent since the highly water-soluble and half-life is just 4 to 5 hours. Novel, innovative drug delivery system for metformin is required to have a better control, convenience, and compliance for the patients. And dual hydrophilic polymer matrix system for metformin will improve the delivery system. It's classically the gastroretentive system, and therefore a combination of DPP-4 along with saxagliptin in a fixed dose formula can help the patient to have a better glycemic control. With that, I thank you very much for the patient listening. I know it's a fag end of the day. You're tired listening to so many lectures, so many speakers, so many kinds of lectures, so many kinds of thoughts. But still, I appreciate those who have come here and listened to me very patiently. Thank you very much.